Today we're going to talk a little bit about death and dying. The funny thing is here is that Americans don't really die. They expire. They pass away, kick the bucket, cash in their chips, breathe their last, and give up the ghost. Death in the American mind is something that's for the distant future, and we all really hope that they find a cure before we actually get to that place. And for the people that do plan for their death and end-of-life care, they kind of hope that they're too old and feeble to really know the difference. And in any given case, death is optional until proven otherwise. And really it's just a topic that a lot of us are uncomfortable with and don't really like to talk about. So on these next two slides, I just have a couple statistics that I found really interesting. You guys can see that most people haven't really planned for death at all. And a surprising thing I found out is that only 30% of Americans actually have a will. And then also a majority of the US adults would actually stop medical treatment because they're in so much pain, which, you know, to me sounds reasonable because I know personally I wouldn't want to spend my life or the rest of my life in pain. Next ones, the top one is for physician-assisted death. It's pretty 50-50, which is due to, you know, people's own opinions. People feel very strongly about that topic, which we heard from who talked about it before. And then the next one, which I found surprising, is about children. And it says a majority of US adults believe that an infant should receive as much treatment as possible in the case of a life-threatening birth defect, even if parents want to refuse treatment. And that's something that can cause a lot of issues depending on where you sit, where your opinion is. And that's something important to note for the last three statistics I kind of pointed out, is that everyone's going to have their own opinion and everyone's going to feel passionately about that opinion. And lastly, cost. We all know that health care is really expensive, especially end of life care. And if you look how much Medicare is paying, if they're paying that much money, it's like crazy to think about the amount of money that families pay out of pocket for health care. There's a study I saw that they looked at 3,000 people. 65% of those people paid an average of $40,000 out of pocket over a 5-year span. And out of the remaining percentage, a small of them were paying upwards of $100,000 out of pocket over that time frame. And that's just a crazy amount of money to me. And next I'm just going to talk a little bit about the treatment options for those with terminal illnesses. Two of them are things that we're pretty familiar with, curative care, which a perfect example is like chemotherapy, or physician-assisted death, which, as we saw before, is only legal in a couple states and they're working on other ones. But I like to add it to this list because it is still an option for a lot of people. They can, whether they're living in that state or they can move to that state. The other two are palliative and hospice. And those are two things that I know I got a little confused, and I just kind of wanted to make it clear for you guys. The two of them have a same goal. They want to provide comfort for those with a terminal illness. But for palliative care, it's a pretty broad term that more or less there's a cure for your illness, but you don't want any extraordinary measures to be taken. And then hospice, it's a service or a system that there's a process to get involved with that. And it's for people who have a time stamp. Like they only have X amount of time to live, and you're only treating their symptoms to make them as comfortable as possible until their time comes.
So no matter what option people choose, if they choose to go a curative path, palliative, or hospice, which can change throughout a treatment process as well, it's all done in different settings. You can be in a hospital. A patient with cancer may choose to go through chemo and then go home and spend time with their loved ones. Or an individual that has Alzheimer's or ALS or any other degenerative disease may choose to be in a long-term care facility or spend more time in a hospital than at home, but everyone has a choice of where they want to go. Particularly hospice, they have hospice centers that their goal is to just make people comfortable, give them a place to die in a way that they feel is right for them, and it helps their families because you can go home and you can go through the process of hospice at home, but you can also choose to be in a facility where there's people there for support and everything that you would need. We, particularly as physical therapists, usually only work with patients that are undergoing curative curative care and possibly through palliative care. But once a patient has decided to go through hospice, all treatments such as physical therapy are no longer done. So we're kind of just helping with the well-being of those going through palliative care and continuing to work with those that are continuing with curative care. But it's really important for us to remember that no matter where you're seeing them, you need to know what their MOLST says, which a MOLST is a medical orders for life-sustaining treatments. And that is going to tell whether or not a person is DNR. So if you have a patient that drops down in front of you and you go to take their pulse and they don't have one, you need to know if it's right for you to be doing CPR on them, because if they've chosen to no longer have extensive measures, you don't want to do CPR on a patient that is signed a DNR, because that can lead to legal issues. And with the patients that are going with the curative matter, even though they do have a terminal illness, they may seek your advice. And we're physical therapists, we're not doctors, so we can't tell them like this is the option for you, but it's really important to know what the options are for them. You need to know the difference between palliative and hospice care. You need to be able to discuss with them, because we're someone that they've got a lot of confidence in if they're continuing to work with us. So if we can kind of give them information, you can tell them about who a palliative care specialist is, give them their number, but don't contact them. Don't make it so that they're being seeked out by someone that runs a hospice care facility, but just give them information, tell them about the long-term care facilities in the area, and just be very supportive for them, because we do have that close relationship and you don't want to cause any issues with them. And it can be really tough working with a patient with a terminal illness, because you know that, in 6 months, in a year, they're no longer going to be coming to see you. You're not going to be working with them anymore. So you just need to be supportive of them and whatever healthcare choices they choose to take.
So patient perspectives or preferences on end-of-life care can vary significantly based on a lot of factors, and things that can come into that are their diagnoses, their prognoses, their age, and personal beliefs and values. So I'm just going to touch on a few studies that we looked at here. One study was on patients with 6 months or less to live with stage 4 cancer. And it looked at middle-aged adults as well as older adults. And middle-aged adults were significantly more likely to elect curative measures or care to extend their life than older adults. And older adults generally preferred to go home to die, in contrast. And we also looked at a study on pediatric patients who had passed away, and it surveyed their families. And with the families, they were significantly less likely than in either of the adult categories to have wanted their child to come home. And that can be because as a younger individual, they're trying to seek to get whatever curative care they can, but it also may be because it's more difficult to manage a child's pain at home, as there are less pediatric specialists available for home care settings. And also the families came to really rely on the physicians and their child's health care team as a support system, as well as for their child's health care. And so even within the subcategories of age group and diagnoses, it's important to remember that each individual can have very personal reasons for choosing one method of care or another. So it's important for patients and families to have this discussion with their healthcare providers on what they would like to have done with their end-of-life care. So the patients want those discussions to focus on their desires for their end-of-life care, as well as their own personal values and beliefs. And the families really want to focus on clearly understanding what their family member's prognosis is, and as well as being given the opportunity to voice their concerns and fears and questions to their healthcare providers. And it's also important to remember when discussing these aspects with their healthcare providers to do so in a compassionate and kind manner, that you're giving them truthful information, but doing it in a way that still allows the family members and the patient to have some hope. So in our study of the pediatric patients that we looked at, many of the family members reported that insensitive comments made by healthcare providers, even if they were isolated incidents, significantly increased their suffering.
All right, so are you good? Very quickly, as discussed, our current societal attitudes and our practice towards death are denial, a hush-hush approach. This is not because we don't understand death, it's more so because of this illusion that we have created from the medical advances today. So there's a lot of things that we've created. There's this premise, this idea that we can prolong life and control death. And this gives a godlike complex to doctors and medicine. Don't get me wrong, medicine has come with great breakthroughs that have answered many people's questions, but not all are fortunate for a definitive cure. This leaves patients, doctors, and their loved ones with one thing, that is hope. They hope in time they find a cure. They hope for a miracle. They hope for just a little bit more time, and mostly they hope for the best. Benjamin Franklin once stated, "In this world, nothing can be said to be certain except death and taxes." Therefore, each and every single one of us is certain that death will come, but when, that remains uncertain. Individuals diagnosed with a terminal illness are given an estimate of how much time is left. This gives them an advantage. They are left with an opportunity to grieve and to accept together as one, as a family, anticipating the inevitable. As stated previously, this is not within our scope directly, but it is within our scope of human compassion. It is still essential to convey a sense of hope, but in combination with acceptance. It all boils down to your perspective, not your age that's going to matter the most. As future healthcare professionals and members of the society, we must be willing to change our perspectives towards death. In order for us to fully accept and appreciate life, one must be aware of death and the additional events to follow. By accepting death and pursuing what is most important in those final moments, we're able to establish a peaceful connotation between death, dying, and acceptance of life. Appreciation of life, I'm sorry. By changing our views and attitudes to acceptance, we're opening a window of opportunities to create and preserve memories with those in those last moments with them.